Nick Majerison here. Welcome to Top Med Talk, and welcome to today's Top Med Talk, Part 2, ASA 2018 San Francisco, Enhancing Recovery from All Surgery, Cardiac, Spine, C-Section, Emergency. This conversation continues from yesterday's Top Med Talk, which is, of course, of the same title, but Part 1. On the way, also, you'll be hearing how you can download the entire Top Med Talk back catalogue. That's coming at the end of the podcast. Before that, though, have a listen to this.
Top Med Talk.
One of the questions that we had from Slido last night was, people want to know kind of specific anesthesia protocols for these patients. What dosage are you using, what drugs, what dosage are you using in your spinals, for instance? Can you walk us through a little bit what specifically your protocol looks like, some different dosing and things like that?
So what we try to do at the University of Washington, we try to sort of like have a very clear structure how to provide the C-section for patients who are eligible for the ERAS protocol. Everybody gets a spinal anesthetic, and that happens after they have received a carbohydrate load about 2 hours before the surgery. We borrowed the carbohydrate load from the colorectal protocol, and then the women get a spinal anesthetic. We use 12.5 milligram of hyperbaric bupivacaine, 100 micrograms of preservative-free morphine, and 10 micrograms of fentanyl. The spinal anesthesia always causes a loss of vasomotor tone and hypertension, and we co-load about half a liter of fluid while we place the spinal anesthesia, and we start a phenylephrine drip about 50 mics per minute for right away when we place the spinal anesthesia for everybody. Unless, one size never fits everybody, but we're talking about a standard case. If we have a severe preeclamptic woman with high blood pressures or other, then we tailor it to the patient.
Sorry to get into the weeds, but how's the phenylephrine infusion prepped? Is it pre-prepped? Is it large volume? Is it small volume? Does it go on a infusion device?
Everything's on a drip.
Yep.
We have a 200 mics per milliliter concentration in a 250 mics bag, which is prepared by pharmacy.
Right.
And then we run it on a drip. We put the patient weight in. We start at 0.2 mics per kilogram body weight per minute, and then we rapidly increase the dose. Usually we double it in order to maintain a systolic blood pressure in a healthy woman around 100 millimeter mercury. It's just because this point flips right over into a whole load of discussions that are happening in the rest of the provision of anesthesia.
Yeah.
Do you use any other vasoactive agents? I know there's a little bit of evidence. I should be more respectful to the people who did the research. There's some great evidence in OB about the potential effects of the vasoactive agents on mum and baby. Is phenylephrine the current evidence-based choice?
Yes. So phenylephrine is the current evidence-based choice. We used to use ephedrine. Mm-hmm. Ephedrine may cause acidosis in a certain subgroups of baby, which we may not or are able to identify. So we've come away from ephedrine. We're using phenylephrine. And there is now, we are also looking at the use as norepinephrine.
I was just wondering.
Which, compared to the phenylephrine, causes a little bit less reduction in heart rate. Yes. So it's better for heart rate, it's better for cardiac output. And we are considering the use for norepinephrine in patients where we are particularly concerned that a drop in cardiac output is not beneficial. Right.
Because, the baby needs that flow. Because
the uteroplacental perfusion has no autoregulation. It's the maternal systolic pressure which guides that perfusion, and So we need to support it.
And are you going to be allowed to give the norepinephrine dilute peripherally? Because this is another flashpoint.
This varies from institution to institution, but I think for a C-section population, we are looking for a pressor which we can give in a peripheral IV, absolutely.
Because there's no contraindication to that. We just tell each other there is, but there's...
I'm not sure there is a contraindication for that. Having worked in 3 countries and in 5 different hospitals, I've seen it all. So
some places you have to give it in a central line of
I know,
ITU,
right?
And other places you can.
They
don't
give
like
it
to in the back of the hand, but they're like a well-sited peripheral IV line is.
I think the clinical pearl rudder is if you use a pressor and you're not getting a response, you should consider perhaps using another pressor which increases the cardiac output a little bit more favorably, like phenylephrine. But in the US, phenylephrine seems to be the pressor of choice. People have a lot of experience with it, and that is a great asset because you can minimize complications and mistakes by, dosing error, confusing the bags, and so on. Familiarity is very important.
Yeah.
So,
sorry to talk to that
point, but it's very important. And what I was going to ask you, you were talking about bolusine and flu bolusine like that. What is the fluid management that you use in the OR?
So we use LR, lactated ringers, half a liter. Usually we are I know for colorectal and for other ERAS protocol, the fluid restriction is a big deal. We try to limit the fluid intake about 2 to perhaps maximum 3 liters for a C-section. I think in reality we end up probably giving about, in average, I would say about 1.8 liters. Yeah. The key thing is that we're able to reduce the phenylephrine drip by the end of the C-section because very often labor and delivery floors are not able to take patients on pressors, and we certainly don't want these women to go to intensive care unit just because they need a little bit more phenylephrine. That would be to nobody's benefit. Yeah. The other thing which affects blood pressure is oxytocin, right? The uterotonic, which needs to be administered once the baby is delivered, so the uterus to prevent uterine atony. And in order to, also oxytocin administration has come a long way, but we also are giving it on a drip in a very regimented fashion. We're having...
Not just blowing it in.
No, we're not blowing it in. No. We're not blowing it in. No.
It happens.
And also... early on, immediately after the cord is clamped, we do delayed cord clamping, which is also part of our ERAS protocol. So as soon as the cord is clamped, we start the oxytocin on a drip, and we start at 15 units per hour until we get the report that the tone is firm, and then we dial it back. Yeah.
So, because there'll be a lot of people listening out there who haven't done OB for a while. What's run us by the delayed cord clamping.
Yeah.
So the delayed cord clamping initially was used to increase to decrease the incidence of intracranial hemorrhage of babies who weren't that well. But now I think most of the obstetricians like to do it for basically even healthy, vigorous babies. And so it increases the hematocrit of the baby, it decreases the incidence of intracranial hemorrhage, and I think I'm out on a limb here, and one shouldn't be on a limb on a lifetime.
So it's okay.
I think it even increases the hematocrit up to 6 months postpartum. Oh. So there's a delayed beneficial effect for the baby. So delayed cord clamping. I think the literature
is squeeze a bit more blood into the baby. Is that what's happening?
It's basically in a nutshell. And the thing is also that the duration of this delayed cord clamping, it varies. I think literature varies from about 30 seconds to up to a minute. Okay. Wow. At our institution, we did a good Swiss compromise, 45 seconds.
Everybody's doing this too, and they're doing it
on
right.
A clock, yeah. We have a clock going, so we really measure that.
Yeah.
Because I remember it just being a scramble for some reason. Like kind of,
Let's get on.
Of course, this as well was decided in an interdisciplinary, context with our pediatrician. Like almost every single step in our ERAS protocol, so we have every player on the table, and everybody can weigh in, and everybody is okay with that plan. Yeah.
And then post-operatively, anything changed dramatically apart from... Because, I mean, traditionally, mums have been allowed to drink and eat and get up and move around.
We would like... I mean, early mobilization is key, right? We would like for them to be as quickly as possible mobile, as quickly as possible eat and drink. And basically, right after the C-section, they are already getting small sips and chips, and then we see how they tolerate it. Sips and chips. Yeah, and mobilization, we're starting to have them dangle on the bed 4 hours after the C-section, and we want them to walk down the corridor at 8 hours. We want the Foley catheter to be removed also at that 8-hour bench. The data is not quite clear on that. Probably with the intrathecal morphine, somewhere between 7 and 12 hours seems reasonable. In our workflow, 8 hours worked pretty well. Yeah.
Cool. Well, any final thoughts about enhanced recovery for obstetrics?
I felt that bringing change was actually less complicated than I feared it would be, but to maintain the change is almost more complicated. So we've been having now ERAS protocol for C-section for, I would say, almost 1.5 years. And I feel like we have to give ourselves a push again to stick to the rules we set ourselves.
Yeah, that's funny. We talk about that a lot here on Top
One
Med
last
Talk.
quick question.
Yeah.
So it's always an important question when you move around the world. Who do you support in the Soccer World Cup?
Oh, my gosh.
Well, now, I mean, I have to support... It's complicated. It's complicated, but, I mean, it would be close to a miracle if for once Switzerland could bring it home. Yeah.
They was do pretty well, didn't they?
Yeah. We're getting there. Yeah.
Sorry,
well, on that note, we could talk on and on for hours about multiple, or most of what we talked about today. But thank you, Dr. Bollag, Laurent, for joining us here.
Thank you very much.
I hope you had a good time. It was
yes,
good. Yeah?
I was a little bit nervous at the beginning, but you managed to relax me. Yeah.
All right. Well, we're here at Smith's Medical Booth, Top Med Talk. And booth 1519, if you're listening and you're here at the ASA, please be sure to stop by and have a chat with us. We also want to let you know if you subscribe during the ASA, the next throughout, well, the rest of today, I guess. Actually, no. We're going to be giving this baby away this morning, aren't we? So it's going to happen. So we have a beautiful Marshall amp speaker. Laurent, what do you think about it?
It's super cool. It has a retro look.
Cool? Yeah.
I don't feel that weight. I think they must have put a brick in there just for effect.
We're going to be playing some jams from that later, right before I have to cry and give it away and then cry. So please, we are going to be drawing for the speaker here shortly. We'll let you know who wins that, and be sure to subscribe and listen. Laurent,
I want to make one final remark. So SOAP, the
please,
Society for Obstetric and Pain Medicine, is working on recommendations for ERAS for cesarean delivery. Perfect. And I believe the committee is working on it, and there will be something for everybody to look up with very tangible and clear information. I think within probably the next few months.
Excellent.
Wonderful.
Excellent. We should see if we can get to the SOAP meeting. When's the next meeting coming up? May.
Oh.
Perfect.
Phoenix, Arizona.
Phoenix
in May.
Phoenix in May. That's great.
Hot. Sunscreen.
That's okay. I like warm weather. We're good. So anyway, thank you so much for listening. Please be sure to subscribe. Follow us on social media, Twitter, Facebook, LinkedIn for all your updates on Top Med Talk. We are going to be putting out all this content throughout the next several weeks. And thank you so much for listening.
We'll be back soon.
Oh, yeah, we will be back soon, shortly.
Top Med Talk.
I mentioned at the start our back catalogue of over 300 podcasts. You can download all of these completely free today. Top Med Talk is committed to open source publishing and will remain so for all new material. As we continue to grow beyond our expectations in subscribers and engagement of thought leaders around the world, we will be diligently working to enhance the experience of our listeners by creating a back catalogue, a highly curated collection of our podcasts, advanced search options and special bonus features. This will be available through our new app at a fee. So we encourage you to download all of the podcasts right now. It's completely free through to the end of this month and contains some absolute classics from some of the greats. Enjoy.